Welcome to lecture 2. This is clinical approach to diagnosing excessive visceral fat in people living with HIV. I'm Roger Bedimo, and this lecture builds on the review of the burden of disease and its consequences and sets the stage for lecture 3, which is treatment options. And here are my disclosures. So we want to review why it is important to diagnose excessive visceral fat in people with HIV, and then look at the foundations for management. So our objectives are as follows. We want to discuss the clinical fundamentals of diagnosing excessive visceral fat in people living with HIV. We then want to explain the keys to detecting excessive visceral fat in the physical examination, and then employ laboratory tests and imaging studies that may assist us in this diagnosis. Let's start with a case. This is a person with HIV, a 40-year-old white woman who has been on antiretroviral therapy for the past 2 years. Has achieved a virologic suppression on that treatment with a viral load of less than 20 copies per ml, and CD4 count that has rebounded to 640. However, since starting antiretroviral therapy, she has gained 30 pounds. Her fasting blood glucose has increased. She reports no change in diet or exercise level. So which of the following statements do you consider to be accurate? A, the IDSA 2024 primary care guidelines recommend annual BMI, body mass index assessment, as indirect marker for visceral adiposity in people with HIV. B, compared to waist circumference and waist to hip ratio, waist to height ratio is a better marker of visceral adiposity. C, visceral fat area is estimated using a single slice imaging on CT or MRI, with that slice being done at T10 level. D, DEXA scan is the gold standard method for measuring visceral adiposity. So let's start with the importance of visceral adiposity in this review of the morbidity and mortality risk among people with HIV and central fat or visceral adiposity that we did last year. It shows clearly here that several clinical parameters can be predicted by visceral adiposity. They go from atherosclerosis to liver fibrosis to NAFLD and cognitive impairment. So this is the response to the IDSA to that fact. The IDSA 2024 primary care guidelines recommend annual measurement of waist circumference. Again, this is waist circumference, not BMI, as an indirect marker of visceral adiposity in all persons with HIV, in addition to routine weight monitoring at every clinic visit. So we need to pay special attention to people like the case I presented earlier, who have rapid weight change, especially when they initiate antiretroviral therapy that contains integrase inhibitors or TAF, or people who have coexisting cardiometabolic disease, elevated ASCVD risk, diabetes mellitus, for instance. How do we do this? Let's look at the physical examination. This should be a bona fide integral part of a physical examination, measuring waist circumference, waist to hip ratio, or waist to height ratio. As we will see, BMI has limited utility for visceral fat because some people, especially athletes, may have a high BMI, but that does not mean that they do have fat. And if you add some laboratory parameters to this, you may get as sophisticated as being able to measure what has been termed the visceral adiposity index. We will look at that. Laboratory markers can support, but they are not specific for the diagnosis of visceral fat. And the standard, the gold standard, is going to be on imaging. You will see here in this infographic to the right, several places where measurements can be taken. And we'll come back to this infographic when we want to compare measurement of waist circumference, hip circumference, and the ratios that are derived from them. Unlike the IDSA 2024 guidelines, this is guidelines from the Obesity Society this year. They emphasize BMI, but I would like to tell you that, as I will show in the previous pictures, BMI is less accurate than waist circumference, but it's important to measure something and assess it longitudinally as a marker for improvement or worsening of cardiometabolic risk, as they do here in the obesity guidelines. Now, the waist circumference is a practical and validated surrogate for visceral fat and is associated with increased cardiometabolic risk in the population. You can see here an example of it. A waist circumference tracks with BMI, but is a better measurement of visceral adiposity. And it's done at the top of the iliac crest with the patient standing at the end of a normal expiration and the tape parallel to the floor. We do have thresholds that are indicative of increased cardiometabolic risk, 102 or more for men and 88 or more centimeters for women. There are lower cutoffs for Asian populations because they incur cardiometabolic risk at a lower waist circumference than other races, as you can notice here. Now, let's go back to the practicality of the measurement. The waist to hip ratio, normal weight central obesity is defined by increased elevated WHR and is associated with higher mortality and morbidity, even if people had normal BMI, particularly in the absence of central fat deposition. So how do we measure this? You can see here that the hip ratio is at the highest part of the hip, and the waist ratio is over here at the level of the umbilicals. And then you can measure weight to height ratio, which is a cutoff of 0.05 or more, indicating increased risk. Again, waist to height ratio may outperform BMI and waist to hip ratio in predicting visceral fat in cardiometabolic risk. This is what I'll show you in the next analysis about 3 years ago of a receiver operating curve analysis for comparison of BMI, waist circumference, height circumference, weight to hip ratio, and weight to height ratio in determining visceral fat levels in diabetic patients. If you're not familiar with these ROC curves, look at the green line, which is a reference line, and every curve, as far as it departs from the green line, it becomes more sensitive and specific. So you can see here that the curve that is the furthest from the green reference line is the weight to height ratio, which is this yellow line here. So tracking right next to it is the weight to hip ratio, which is red here. So these are measurements that are relatively easy to make at clinic level, in clinical setting, but that gives you a fair assessment of how cardiometabolic risk can be assessed and managed in these people with HIV. And this is an example here in this Annals of Internal Medicine paper 10 years ago that shows that even with normal weight, waist to hip ratio is a significant predictor of cardiometabolic risk when BMI was not. So that is a very important fact. Now, like I said earlier, if you wanted to be more specific, you could look at the visceral adiposity index, which is an empirical mathematical model, gender-specific, based on simple anthropometric BMI and waist circumference, and functional parameters like triglycerides and HDL. And measuring this in these papers that are referenced below have been shown to be an even better predictor of visceral adiposity in the general population and hence in the people living with HIV. Now, we have looked at clinical measurements in the clinic, and we have looked at some labs that may complement the clinical measurement. However, the gold standard being imaging, and I can show you several types of imaging parameters, imaging procedures here. One is the DEXA scan, which we have been familiar with for bone mineral density, but it can also assess body composition and estimate central fat is practical and is widely used. However, the gold standards are CT and MRI for quantifying visceral adipose tissue, and you can see here. One that is less commonly used in clinic here in the United States is the bioelectric impedance analysis, as measured here, is sort of like a souped-up scale, and that also gives you an assessment of the percent body fat. But widely used because of its lower cost and ready availability is the ultrasound. Got it. Then, so these are all methods, measurements of visceral fat, and I can repeat that CT and MRI gives you a more granular picture, so they're the gold standard. So let's summarize the methods for measuring visceral adiposity in the clinic. Again, you are balancing ease of use with accuracy. As you move from the left to the right, the ease of use is the physical examinations in the clinic, and the more accurate being the imaging data, with at the far right, the most accurate being CT or MRI. And then you can see here that they give you added precision, but sometimes at a higher cost and lower availability. And here is to zoom in on those imaging modalities and how they perform. For the DEXA scan, there's a visceral fat depot that is measured in a 5 centimeter wide region at the level corresponding to L4. Again, not T10, but L4, slightly above the iliac crest. Similarly, CT and MRI, which are the gold standard, are estimated using a single slice imaging also at the level of L4. And the cutoffs for visceral fat area with these imaging modalities is about 100 centimeter square that has been applied to study the risk of cardiometabolic diseases. So let's go back to the case and the correct answer, which is the 40-year-old white woman who has been on antiretroviral therapy for the past 2 years. Virology suppressed A4 count has rebounded, but has gained 30 pounds. And in this analysis, the IDSA primary care guidelines recommend annual waist circumference, not BMI. So answer A is not correct. Compared to waist circumference, waist to hip ratio, and waist to hip ratio, waist to height ratio is a better marker of visceral adiposity, as we've seen. So answer B is the correct one. And visceral fat area is estimated using single slice image MRI at L4 levels, not T10. So answer D, answer C is not correct. And DEXA scan is not the gold standard, but the gold standards are CT and MRI for measurement of visceral adiposity. So let's take a couple of minutes to give you a summary. It's important to assess visceral adiposity in the clinic as they predict cardiometabolic risk. This can be done through performing physical examination, and in which waist to hip ratio, and even better, waist to height ratio are the better markers. Laboratories can give you supporting evidence, but they're not diagnostic. The gold standards are using CT or MRI, but these are, of course, costlier. It's important to employ this imaging diagnosis if you have a person, especially starting antiretroviral therapy and is gaining excessive amount of weight. So this is our summary. Key takeaways here is that routine risk-driven evaluation is essential. Physical examination remains central, and imaging has precision in selected high-risk or unclear cases. So having established diagnosis strategies, we now explore in the next lectures therapeutic treatment options for people living with HIV who have excessive visceral fat. Thank you.